Okay, Bismillahirrahmanirrahim. Assalamu alaikum. Khdayo ki shirtul roq jor asay. Nan topic chida zaman postpartum hemorrhage bara kida. Chida important topic da the OBS emergencies ke shamilegi. No, first of all, the definition more than 500 ml of blood loss following normal vaginal delivery of the fetus, yeah, 1000 ml following cesarean section. This is known as PPH, yeah, postpartum hemorrhage. Clinically, the amount of blood loss from or into the genital tract, which will adversely affect the general condition of the patient. Hemorrhage leading to fall in hematocrit by 10%. Incidence is 1%. No, then next slide types of PPH. There are two types basically. Your primary PPH or secondary PPH. Now, primary PPH, in primary PPH, bleeding occurs following delivery of the baby up to first 24 hours after birth of delivery. Primary further types thing. Yeah, the third stage hemorrhage. Next is true postpartum hemorrhage. Third stage hemorrhage that is defined as bleeding which occurs before the expulsion of placenta. At the third stage of labor, as you all know, is the time from delivery of the baby till complete expulsion of placenta from the genital tract. Now the placenta delivery na makhke, matlab baby deliver shwa da placenta na the deliver shwa. Kam bleeding chikegi matlab 500 ml of blood during normal delivery or more than 1000 or more than 1000 ml of blood after cesarean section before expulsion of placenta. This is known as third stage postpartum hemorrhage. देखिए examples से placenta accreta या retained placental vagina kegi. Next is true postpartum hemorrhage. True postpartum hemorrhage occurs after expulsion of placenta. मतलब baby deliver show placenta expel show और again pass patient PPH तलाड़ा मतलब more than 500 ml या 1000 ml bleeding kegi. Now that is known as true postpartum hemorrhage. The second type of postpartum hemorrhage is secondary or delayed or late postpartum hemorrhage. That is, the bleeding occurs following delivery of the baby after 24 hours up to 6 weeks postpartum. No, that duration ke chicken females the bleeding kegi ageta mangwayu delayed secondary or late postpartum hemorrhage. No, next that is primary postpartum hemorrhage. The causes chishegi. What are the causes? The causes are mainly atonia, traumatic, mixed, or coagulopathy. Atonic PPH, it contributes to 80% of postpartum hemorrhage. And postpartum hemorrhage, major cause to the atonia, and that is 80%, which counts for 80% of postpartum hemorrhage. This is the most commonest cause of PPH. And the causes are a faulty contractions of the uterus. Anemia can also do postpartum hemorrhage due to atonia of the uterus. Next is prolonged labor, anesthesia, anesthetic disorders like halothane ether or cyclopropane, uterine fibroids, precipitated labor, malformations of uterus, septate uterus or bicornuate uterus, antepartum hemorrhage, initiation and augmentation of delivery with oxytocin. Next factor which contributes to postpartum hemorrhage is the trauma. And trauma, it can be due to the lower genital tract, like cervix, vaginal lacerations, or any perineal injuries, paraurethral injuries, or uterine perforation. Next cause can be a combination of atonic and traumatic. The next is blood coagulation disorders, abruptio placenta, jaundice, thrombocytopenic purpura, and HELP syndrome. The so lectures slides summarize the 40s. If you remember these 14 the past 3 lecture slides, sorry, the PPH causes to explain the 40s pe number 1 is stone. No, as we told before, 80% of the PPH contributes, the atony contributes to 80% of PPH, and the most common cause. So the first one, T, is for tone. The second is for tissue, for example, the retained products of conception, any piece of placenta is remain, membranes are remain. So this leads to cause PPH. Next is trauma. As I told you before, the lower genital tract traumas. For example, cervical tears or lacerations or vaginal tears and lacerations. And the final is thrombin and coagulopathies like hemophilia, von Willebrand disease, etc. Next slide. Okay, next we come to diagnosis. How PPH is diagnosed, how we say that patient is gone into PPH. This is the vaginal bleeding, and zaruri na that the vaginal bleeding it can be revealed or it can be concealed. Next is alteration. Okay, alteration in pulse, blood pressure and pulse pressure of the patient. And the third one is flabby uterus and atonic uterus. Yani for abdominal uterus palpate ka uterus is not contracted, it's soft. So we come to know for that the uterus is not contracted. Okay, the clinical findings in PPH. Clinically, masalan, the amount of blood loss to the defined cases kam taghirat razi. Amount of blood loss and degree of shock. Degree of shock is compensated, mild, moderate, or severe, and the amount of blood loss in compensated shock is 500 to 1000 ml, that is 10 to 15%. Blood pressure changes, blood pressure changes, blood pressure is almost normal, and some sinus symptoms is palpitations, patient complains of dizziness, and she is tachycardic. In mild, there is 1000 to 1500 ml of blood loss, which is 15 to 25%. There is slight fall in blood pressure. That is, the blood pressure might be 80 to 100 millimeters of mercury, and patient complains of weakness, and she might have sweating, and she is tachycardic. In moderate, this is 1500 to 2000 ml of blood loss, and blood pressure changes. This is marked fall in the blood pressure, like blood pressure 70 to 80. Signs symptoms: patient is restless, clinically she is pale and oliguria. Severe is 2000 to 3000 ml of blood loss, and the blood pressure is profoundly fall. It is 50 to 70 millimeters of mercury, and patient may be collapsed, air hunger, and in urethra. Next slide. Okay, after the diagnosis and the clinical findings and the risk factors for PPH, we come to the prevention, how to prevent PPH. So first, we should know the diagnosis, and when we label the patient that she is in PPH, this is important. Patient either normal bleeding after vaginal or even after doing cesarean section, that is normal. No blood amount zaruri that 500 ml or 500 ml blood loss, then we say that patient is in PPH. So for this, we have some preventive measures how to prevent PPH. Uterine tonic drugs, the routine oxytocin administration का third stage of labor. मतलब वलादत होगी, mushroom पैदा किएगी, अगर ना पास placenta deliver किएगी, then we give almost anterior shoulder to deliver she. हम prophylactically work or routine administration, like after delivery of the baby and placenta, we give 20 units of oxytocin and 1 liter of normal saline, and it continues for 4 hours. Next is routine prophylaxis with oxytocin results reduces the need for these drugs. Routinely in this the management of third stage, active management of third stage of labor, point that. Next, early recognition of PPH, that is an important factor. The management early recognize she. Okay, I think buzz students pick. No, we'll go a little bit slow. Management ke early recognition of PPH is a very important factor in management, and established plan of action for the management of PPH is of great importance. To next slide, please, like that, Sam. Okay, management plan ke mangrazu. There is a lot of steps. The number 1 step to the initial assessment and treatment. Yani your patient ke PPH nazi awal bayad assess karo. Initial assessment ke patient resuscitation da. Make sure you have 2 large bore IV cannulas. Start oxygen by mask. Monitor blood pressure, pulse rate, and urine output of your patient. Urine output monitoring la para bayad catheter rolleri patient, Foley's catheter, oxygen saturation by record sheet. Next point is assess the etiology. Patient PPH talada initially resuscitate your patient. Again, pas etiology se shayada cause of PPH se shayada PPH wale patient PPH talada. Agala para explore the uterus. Matlab either uterus atonic da या मसलन there is any tissue remain يعني كم part of placenta ته deliver شوی ده هغه باید proper وکتل شي چې complete deliver شوی ده یا کم part cartilage in the placenta پاتې ده membranes خو نه دي پاتې هغې نه پس بیا lower genital tract assessment ده باید lower genital tract explore شي وکتل شي for any cervical tears or lacerations or any vaginal tears and lacerations and then review the history of your patient مطلب مخکې که تاسو history اخیستل شوی ده د patient باید you should make sure چې patient هم coagulopathy خو نه لري څه blood disorder خو نه ده د patient هغه باید explore کړئ تاسو خپل د patient history دوباره یو ځل review کړئ او بل دا چې locally مطلب وګورئ چې lower genital tract کې کوم clots پاتې uterus کې دننه clots پاتې هغه clots باید remove شي next is laboratory test هغې لپاره CBC ډېر زیات ضروري ده چې وګورو موږ څونه hematocrit found شوی ده HB د patient کتل دي هغې نه علاوه coagulation screen کول ده and blood group and cross match This is step 1, which is initial assessment and treatment of your patient. Next, we come to the step 2, that is directed therapy, according to the cause. So the PPH cause accordingly by the treat. Masalan, tone ke problem da. Uterus is atonic, then give massage. Compress the uterus and give oxytocin and oxytocin drugs. Next, if there is any tissue remained, for example, any products of conceptions are remained inside the uterine cavity, aga by manually remove shi. Landi kada ka picture ta so gore de ke manual removal da or by manual compression of the uterus. Da picture ke by manual compression of the uterus ho da shwa. Then next picture ke bya manual removal of placenta da. So as I told you before, 4 T's kata so payado sati de ke tool share cover ki cause and according to the cause treatment tissue tone and then tissue manually remove ke kam part the placenta khapal dobara review ke check ke che complete out shawai da kana da shawai any membranes kapati di aga bayad remove shi next T is for trauma masalan ka uterine for example if there is uterine kasarna shuru ki uterine inversion the inversion by correct if there is any tear or lacerations in the lower genital tract masalan cervix ya vagina aga by repair shi okay uterine rupture the rupture by identify shi aga na pas bad treat shi that is laparoscopy and all that. Next is thrombin. If there is any coagulopathy by reverse anticoagulation and makes anticoagulants work over she patient and replace factors. For example, her factor she deficient replace she. Next slide. Okay. Next, we come to the drug therapy for PPH. Drugs come the sona dose the side effects especially when they are contraindicated to by the small nishi. Number 1, which is easily available and oxytocin routinely used the 10 units IM workout after delivery of the anterior shoulder of the baby and 5 units IV bolus workout in case patient PPH 5 units IV bolus and then 10 to 20 units 1 liter of normal saline add and then patient continue. Side effects the oxytocin usually has side effects painful contractions uterine contractions in uterine contractility enhanced it can cause a painful contraction to the uterus, nausea, vomiting and water intoxication. These are the minor side effects of oxytocin. It is contraindicated in patients who are hypersensitive to the drug. Next is methyl ergo Novine. It is 0.25 milligrams IV workout every 5 minutes repeat kg. Maximum 5 doses, 5 doses workout kg. Side effects peripheral vasospasm, the hypertension, then nausea, vomiting. So be aware if your patient is hypertensive, then don't give this drug. Or if the patient is hypersensitive to the drug. Next is carboprost, which is prostaglandin F2 alpha. It is also given 0.25 milligrams IM. Repeated every 15 minutes as needed, and then maximum we can give 8 doses. Side effects are flushing, diarrhea, nausea, vomiting. It can cause bronchospasm, flushing, and restlessness and oxygen desaturation. Okay, it's contraindicated in patients who have active cardiac, pulmonary, renal, or hepatic disorders, or if the patient is hypersensitive to the drug. The last one is vasopressin. We give 20 units diluted in 100 ml of normal saline, 10 units per ml, and like Dr. Sabka slide, they're small. Thank you. And the side effects are acute hypertension, bronchospasm, nausea, vomiting, abdominal cramps, angina, headache, vertigo. Even it can cause death of the patient with intravascular injections if you give it. Okay. And the contraindications are again to coronary artery disease, patient who are having coronary artery disease, hypersensitive, or a patient is hypersensitive to the drug. Next slide. And actually the tissue is retained, and this is the picture showing manual removal of placenta. Okay, next is continuation of the management, and the third step is intractable. Step one was initial assessment and resuscitation of your patient, then identification the cause, what is the cause, and then directed to the cause management. And the third step is intractable PPH. मतलब अगर टोल कारों जो माता स्टमक के वाले, for example, that टोल के problem दा no by manual massage दा غينا पास मतलब oxytocin work كول दा हम दा غسك TRZ अगर TRZ identify كول دي repair كول دي and كذا manage tool points شماتا سوالي دا كار نكينو أغينا pass. The third one is intractable PPH, which is not controlled by all the above steps we mentioned. No, you should call for help. Senior obstetrician by the flori, surgeon availability, and a statistician, lab and ICU by the inform you that you're having a patient which is an intractable PPH. Local control among manual compression, pack the uterus, vasopressins work in plus minus embolization. BP and coagulation, BP laparic crystalloids work at so blood available KG, and then coagulopathic blood products. That either you give whole blood, concentrated blood, or fresh frozen plasma according to the problem. Next slide, their side. The fourth step is surgery. Four-step surgery that is repair of laceration, kakam laceration, repair sheet. Like the vessels, you can go for uterine, internal iliac, or ovarian arteries, and the last हर बच मंग कौवा का फील की नबियाबल हिस्ला रन पाती की देने लावच मंग hysterectomy को, that is the removal of the uterus. Next slide, sir. For post hysterectomy bleeding, post hysterectomy na pass some patient masalan bleeding continue ke, then abdominal packing and angiographic embolization of the arteries. This the next picture the bean and sutures show, okay, and this is before you go to hysterectomy. Bean and sutures apply she kada kar ke and go, there's no need for going into hysterectomy or kada kar no, then go for uterine artery ligation, internal iliac, or ovarians, and finally hysterectomy them. A summary, as I told you before, amaga 4 T's kata so payado sa tone, tissue, trauma, and thrombin. Then you can manage it easily. For tone, rule out uterine atony. If there's any atony, then palpate the fundus. Fundus ka palpate kiyegi. Khusai da kana palpate kiyegi. The uterus is not contracted. Is it atony? Then massage the uterus. Give oxytocin and methergin. The methergin, make sure that your patient is not hypertensive, because methergin is contraindicated in hypertensive patients. Next slide. Next is for tissue. As I told you before, tissue rule out retained placenta. First tone normal, the uterus contracted, the patient bia hum bleed ke de matlab da chekam part of placenta ya membranes pathi de no placenta ugore ka placenta complete out shroy the membranes or sara de say well agar nishta no bia matlab placenta by manually remove she, and then inspect the placenta for missing cotyledons, explore the uterus, treat abnormal implantation. Masalan placenta previa accreta, increta per creta kai no aga surat by the remove she parts of placenta chikam pathi to so parts the remove ki aga pure PPH na manage ki. Next, T was for trauma. Trauma again, rule out any cervical or vaginal lacerations. Make sure you have good exposure. Expose inspect the cervix and vagina. Worry about the slow bleed. بعض وقت مثلا water bleeders جاغا neglect کیږي یا miss کیږي نو bleeding continue کیږي نو دې لپاره همیشه slow bleeders یا کوم water bleeders چې هغه باید احتیاطاً کتل شي. And then treat any hematomas. کوم hematoma جوړ شوی هغه hematoma باید treat شي. Next slide. Next and the last was thrombin. Replace with blood, as I told you before, or fresh frozen plasma or platelets, rich plasma according to the disorder. I think this was the end. Next slide, like I said. Yes, this was the end of the lecture. I hope you have understood the definition, its incidence, management, diagnosis, and that was the end of the lecture. I hope that's what I say.